Okay. So when she was manic one time, she believed that she traveled to Mars, right? She went through space. She had this huge hallucination of traveling through space. And she sort of believed that she had that experience. And she still holds on to that, right? Because it felt so real to her. And it was so magical and freeing and such a powerful, moving experience. It's sort of like an LSD trip, right? You feel like you really are experiencing it. So you can have hallucinations and delusions associated with mania, associated with depression, or independent of those things, right? And so schizophrenia is not really a high. It's not really the same thing as a mania. Does that answer your question?
Yeah, I guess the thing that's mania is I've seen with a lot of these not just schizophrenia, bipolar, but the common thread that I'm seeing in a lot of them is dysfunctioning with the dopamine or serotonin, or some of the other brain chemical factors. But what I'm trying to figure out is what causes someone to have this type of disorder versus another person having this other type of disorder, even though it's a similar chemical.
It works on the similar chemical pathway. So do you remember when Dr. Boser showed that video and it was talking about how just slight changes in the way that the brain is interacting, like it might be an extra release of a neurotransmitter versus a neurotransmitter not taking up the other neurotransmitter quite so well, and how the different drugs have a different interaction with the brain even though they're working on similar neural pathways. That's going to be true of a lot of these disorders. So like GABA is implicated, and an overabundance of GABA versus an underabundance of GABA. So there are some explanations for that, but again, just in the interest of time, I'm not going to get into it. But you can look it up in your bio foundations or in an abnormal book. You should be able to find where you see like the serotonin implicated in depression versus how it's impacted in schizophrenia. Okay. So yes, you're right. And there is an answer, but I don't have time to go into it right now. Okay. Externalizing disorders. So I've categorized sort of internalizing disorders versus externalizing disorders just so that you have a little bit of a framework for that. And this is not how it's categorized in the DSM, but it's helpful to me to characterize them in this way. So an externalizing disorder are things like oppositional defiance, conduct disorder, or intermittent explosive disorder. What do you think is the common thread for this? Negative interactions with others, right? These all yield negative patterns of interactions with other people. These are what you would call acting out disorders, right? So a child who is oppositional defiant is somebody who you tell them to do something, they're definitely not going to do it, right? So that's the oppositional defiant child, which can typically lead into a conduct disorder. So conduct disorder is sort of the next level up from oppositional defiant disorder, which requires violations in individual liberties or laws, right? So conduct disorder is not just I'm going to defy you, but I'm going to defy the law and I'm going to do what I want, right? So conduct disordered kids are the kids who steal cars, who are maybe sexual predators. So conduct disorder is the next level up. And that pathway goes oppositional defiant to conduct disorder to antisocial personality disorder. Does that mean that everybody with oppositional defiant disorder winds up with antisocial personality disorder? No. It is very common to outgrow at any level, right? So you can outgrow oppositional defiant disorder, particularly with parent management training. Conduct disorder usually requires sort of the next level. So instead of just parent management training, we get in other systems. So you pull the school in, you pull judicial systems in, you pull whatever community support you can. So that's the multi-systemic treatment. And then we look a lot at prevention for these. Your internalizing disorders, so instead of the acting out disorders, your internalizing disorders are the ones where you turn the negativity or the difficulty or the discomfort inward, right? And so you see this for mood disorders and anxiety disorders. So like with major depressive disorder, You have to have 5 symptoms. They have to be present for 2 weeks. So you have to have a pretty significant chunk of symptoms in order to meet the diagnostic criteria for a major depressive disorder. There are persistent depressive disorder, which used to be called dysthymia. Reduction in symptoms, but it has to go for 2 years, right? So it has to last for a really long time. And this is the only one that I really take issue with, the classification. So disruptive mood dysregulation disorder is classified with depression, but is very much an acting out disorder. This disorder was developed with the DSM-5 because what we were seeing was a lot of children misdiagnosed as bipolar, pediatric bipolar, because there wasn't a diagnosis that really fit them. So this disruptive mood dysregulation disorder, the DMDD, when the DSM-5 came out, the people in my field who worked with kids were like, hallelujah, something that fits, because there wasn't anything that fit up to this point. These are the kids who throw outrageous tantrums that you just really can't contain. They don't really show up on the autism spectrum, right? They don't really pop autism. They don't really have bipolar disorder because they don't have the distinct periods of mania or depression. They are just dysregulated kids. Kids who are uncomfortable in their bodies, or who just cannot tolerate no or anxiety, or they just don't tolerate things well, right? So I worked with a child with disruptive mood dysregulation disorder. I diagnosed him with this. He was a kid who his teacher would tell him to sit down, and he would just lose it, and he would leave the classroom. And when I met him in the guidance counselor's office, which was a whole classroom because she would do classroom guidance. He was in that office. They said, we need the psychologist to come down now. And he was in there, and he was just intentionally knocking over every chair, walking around the room, knocking over every chair. He wouldn't talk to anybody. He would look right at you, and he'd knock it over. He was pretty compliant sometimes, but other times he just would lose it, and he climbed under the table and wouldn't come out. And so eventually I was able to get him out, and we were able to talk about it, but he is somebody who fit this diagnostic criteria to a T. His mom came in and said, please evaluate him. I don't know what to do. I don't know what's going on. Like, he'll melt down, and he'll melt down for 3 hours. He will cry until he just falls asleep if I tell him no about watching a television show, or, not getting his way for whatever reason. And so we see that sometimes. We see those kids who just cannot get themselves back under control, right? Most kids, you tell them no, they don't like it, they fuss, they fight, and then they're kind of like, all right? So DMDD is the kids who just can't get themselves back online.
How long does that last?
The disorder, it's a pretty new disorder, right? And so we don't have a lot of data on it, and we don't really know a lot about the etiology either, right? So we don't know if this is something that is neurobiological, or if this is something that is a result of not hearing no to talk about the video that we were talking about before.
Are there certain forms of therapy that are more effective than others for this?
Yeah. So with DMDD, a lot of times what we'll do is ABA, applied behavioral analysis, and we'll focus really, really strongly. So in ABA, you look at the A, antecedent, then the behavior, then the consequence, and then in order to change the behavior, you can either change the antecedent or the consequence. So in disruptive mood dysregulation disorder, you focus a lot on the antecedent to try to change the behavior, and then you also teach frustration tolerance skills. So you work very much on self-soothing, how to calm yourself down, and you have to really explicitly teach those skills.
Could this be comorbid with ADHD?
Yeah, it definitely can be comorbid with ADHD. They usually present as, usually it's pretty clearly one or the other.
Because I know, there's a kid that goes to Chamberlain, he flips over chairs, throws clipboards, he hit his teacher, and he has ADHD, but that doesn't sound like ADHD. whenever you talk about this now.
Mm-hmm.
It just makes me think. I know I'm not
No,
trying
no.
to do it. It just makes me think about it.
No, and you know, one of the things that we talk about in my abnormal class, and I talk about in the graduate level abnormal classes that I teach, is that diagnosis is half art, half science. And I've gotten psych reports and I've been like, nope, wrong, you know, when I meet the kid. And I'm guessing that maybe somebody got one of my reports at some point and said, nope, wrong, right? Because we're not to the point where we have like the neurobiological stuff to like look at a brain scan and say ADHD or schizophrenia or something else. We're just not to that point. So all we can do at this point is measure behaviors. And so at some point somebody maybe measured his behavior against the standard of ADHD and he met diagnostic criteria, but maybe that's not the best fit diagnosis. And obviously I'm not saying that it's not, but sometimes there's a better fit diagnosis. So for me as a psychologist, that's why psychometric measures are so important, and having a variety and observing behavior in a variety of settings and having multiple reporters, all of those things sort of come together to create the picture of what the best fit diagnosis is. Because somebody might meet diagnostic criteria for ADHD but really have DMDD, and this is a better fit, and this is going to be a better system for treatment for that person. Right? That's why finding the correct diagnosis is important. Yeah.
Like the kid is on Vicodin for ADHD, I think. Or Vicodin? No, not Vicodin.
Vicodin is a painkiller.
Oh, not what I mean.
Vyvanse?
Yes, Vyvanse.
Uh-huh.
And he is on that. Would that make him, like, if he doesn't have ADHD, would that cause, like, would it work?
Vyvanse, I think Vyvanse is one of the non-stimulant ADHD medications, so I don't know that.
I think it's Vyvanse.
Yeah, so it's hard to say. Like let's say for example, a child has anxiety, right? And anxiety can manifest in children and look like extreme irritability, okay? So I go ahead and I do my evaluation, and I only have 2 hours to do an evaluation for the kid. I don't have time to do a lot of classroom observation or to talk to his teacher and to talk to several different people. I've only got 2 hours and I got to just get this done, right? So I look at the kid. They are inattentive in class. They're not paying attention. They are irritable. They have some outbursts. So then I'm like, oh, okay, so this is inattentive subtype ADHD. I don't have time to do anything else, so I'm going to diagnose them with that. And then they put him on stimulant medication. Stimulant medication can make anxiety symptoms worse, right? So that's why it's really important to be able to have the resources, both cognitive and physical, to do thorough evaluations. This is also the reason that psychologists get real like about medical doctors who do a brief screener checklist and give somebody medication based on that screener, right? Because sometimes you can make the problems worse. Okay, anxiety disorders. You've got your specific phobia, which I've listed the most common types. You've got social anxiety, panic disorder, agoraphobia, and generalized anxiety disorder. I'm going to go out on a limb and say I'm guessing y'all probably could feel the difference between those different ones. Is that true? Okay, so we won't spend a lot of time looking at that. Know that in this age group, this population, anxiety has superseded depressive disorders in terms of the most common presenting problem, right? And there are lots and lots of social factors that contribute to this. But anxiety is the number one problem now, not depression. For years, depression was. So for treatment recommendations for anxiety or depression, we use CBT a lot. CBT stands for Cognitive Behavior Therapy. What were the two terms that you weren't familiar with?
There was a lot. It was like reflective speech.
Okay, so reflective, I'll go over these real quick just so you know. Reflective speech is reflecting back the emotional content you hear in what somebody says. So I'm hearing.
That was pretty much word for word what it said.
Right?
I just didn't know.
Yeah. So like I'm hearing that you're anxious because you're not familiar with the term reflective speech. Is that right? That's reflective speech, right? You said challenging the.
Is it questioning the evidence?
Okay. So when we're looking at this ABCDE model, this is a really simplified Albert Ellis version of cognitive behavior therapy. He calls it REBT, and rational emotive behavior therapy, but it's basically the same kind of a principle. This is a different ABC. There are lots of ABCs in psychology. Lots of triangles too, triads. So in this one, you have an activating event is A. B is your beliefs about the event, and C is the consequence. They're the emotional consequence, right? So this is the example I do because I teach this in my adjustment class. I'm walking down the path between the cafeteria and the student center, and somebody bumps me, and I get mad. I bow up at them. You know, bump me? How's that going to be? Right? Why would you do that, right? How are you going to disrespect me like that? How are you going to get in my face? There's plenty of room. Why would you bump into me? Like, you're just trying to pick a fight with me, right? So my anger is my C, my emotional consequence. But all those things I said, there's plenty of room. You're just trying to pick a fight with me. This is disrespectful. Why would you do this? Those are all of the beliefs about the event, right? So challenging the evidence is this D, disputing. So I find out what makes me have the most strong emotional reaction, right? And I find out what thoughts associated with it, right? So for me, my anger, my hottest thought might be, this is disrespectful. I don't deserve this. So challenging the evidence is asking why don't you deserve it? What might be a different explanation? So you challenge the evidence for the thoughts, right? You challenge that thinking, yeah.
So what's the difference between that and then the other one was challenging an idiosyncratic thinking or something? Idiosyncratic, it was something like that. I have no idea where to get what that is.
I'll have to look at it.
Meaning, idiosyncratic meaning.
I'll look at it. Let me look at it, because I don't want
There's
to...
like a lot of questions that have those.
Idiosyncratic meaning? Okay, that must have been a part of that particular textbook. Like, that might have been a trope that they were really focused on. That is just not...
I didn't know if it was the answer, but it was an option.
I'll look it up. Help me remember, Reagan, and I'll go back and I'll pick it up. But so you dispute it, or you challenge the evidence for the thought, right? So my thinking might be, nobody should do that to me, right? Or this is disrespectful. I shouldn't have to experience this type of disrespect. And then I challenge that by saying, could there be another explanation, right? Could it be that they were looking at their phone and they accidentally bumped into me because they weren't really paying very close attention, rather than it being a direct attack to me as a person, right? So then I'm disputing it, or I'm challenging the evidence, and then I come to a different perspective, right? This is the negative triad, the Aaron Beck's negative triad for depression. Like, these things support a depressive mindset. Okay? So we also look at challenging, so we challenge these things. Again, that's looking at challenging that cognition, the thought in CBT. The B component for CBT, behavioralism, or behavioral therapy, is things like behavioral activation, faking it till you make it. Okay? So there's your, let me see. The other thing that I'll say real quickly is systematic desensitization is the preferred treatment for phobia, specific phobia. And what we do is we create a fear hierarchy. I find out what makes you the most anxious, and we move progressively up the hierarchy, right? And so I expose you to this. Let's say you have a fear of spiders, right? So first, I draw a little spider on an index card, right? So that's a pretty abstract version of a spider. So I expose you to that stimuli till you can experience it without having the fear reaction, right? Then we move to a photograph of a spider, right? And then we move to a toy spider, and in each level you stay with it until the fear response calms itself down, because it does eventually. And then we move to an actual spider being near you, not on you, but near you. And then we might move toward like putting a spider on your hand. You're like, nope, that's where I draw the line. But that's what systematic desensitization is, right? So we're systematically desensitizing you to the fear response. The obsessive compulsive disorders, woo, this is lots of information. We're going to go fast. Obsessive compulsive disorders, OCD, body dysmorphic disorder, hoarding, trichotillomania, excoriation. Trichotillomania is hair pulling. Excoriation is skin picking. These require you to have obsessions and compulsions, right? So in order to be on this OCD spectrum, you have to have both obsessions and compulsions. Very different from OCPD, obsessive compulsive personality disorder, which is more along the lines of extreme perfectionism. OCPD you can think of as extreme perfectionism, not associated with OCD. Okay? You don't have obsessions and compulsions with OCPD, which is really confusing, and I don't know why they don't change it, but it's been around for a while, so I guess. So for this, treatment recommendations are medication and exposure and response prevention. So in exposure and response prevention, what you do is you expose somebody to something that's going to cause an obsession, and you prohibit them from doing their compulsion to calm the anxiety, right? Again, what you're doing is you're teaching somebody to experience the discomfort, live with the discomfort until the discomfort subsides, like a wave that moves back off of the ocean, because that happens, right? So if you are prohibited from checking to make sure your door has been locked at night, you might get super, 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 super anxious, but then it kind of begins to dissipate after time, right? So exposure and response prevention is the treatment of choice. Trauma and stressor related disorders. This is your PTSD and acute stress disorder. These are the common things that are associated with it. You've got to have intrusive thoughts. You've got to have avoidance behavior. So I've worked with a soldier who came back, and they couldn't drive down the road and see like a garbage bag on the side of the road because they were so used to experiencing IEDs on the side of the road. So then they just stopped driving altogether, right? So that's avoidance behavior. You have negative alterations in cognition and mood, and then you have changes in arousal. So like hyperreactivity. So I hear somebody drop a pencil, and I'm immediately transported back, or I'm hypervigilant. Okay. Acute stress disorder is within a month after the stressor. PTSD is beyond that. Treatment recommendations are SSRIs, imaginal exposure, which is sometimes called prolonged exposure. Again, what we're doing is living with the discomfort until the discomfort subsides. So keep that in mind. Like, a lot of the treatments that we have are about teaching people how to calm their bodies down, calm themselves down, to experience the discomfort until the discomfort subsides, to live mindfully in that moment until it passes. And to integrate, so part of the recommendations for prolonged exposure, oh my gosh, is integrating it into your story, your narrative. Okay. We've got dissociative disorders. The most common one that people know about is dissociative identity disorder, formerly called multiple personality disorder. This is usually a fracturing of the psyche related to huge trauma early in life, okay? And so the psyche fractures into multiple personalities to adapt and to survive. There's not a lot of efficacy studies, but generally in this highly specialized field, what we do is to try to integrate the different personalities, make aware of and integrate the different personalities. I'm not trained in it. I don't know anybody who is. It is really, really highly specialized. And you can do more harm than good if you try to treat this and you're not qualified to do it. You've also got dissociative amnesia, which is lack of memory, right? You lose memories for a period of time, and then depersonalization or derealization, feeling like you're outside of your body. I feel like I'm in a balloon looking down on my body, right? I look down and I see that hand, but it doesn't look like my hand. It doesn't feel like my hand. That's depersonalization. Somatic disorders, there are lots. Treatment usually involves in getting primary care physicians associated. You get them involved. I have until, what time do we finish? At 40 after?
10:40.
Oh, I was like thinking I was like, oh my gosh. I thought I was done. Okay, sorry. Great. We got so much time. Relax, tell you more. Okay, so somatic disorders are those things that are physiological manifestations of mental processes, right? So things that either we, like in the case of malingering or factitious disorder, where we're faking either psychological or somatic symptoms for either gain or not for gain, right? So in malingering, somebody who's malingering might file workers' compensation because they hurt themselves, or because somebody yelled at them and they had some psychological damage, right? But they're getting workers' compensation for it. Or, you know, those people who you rear end somebody and there's no damage to either car, but I gotta go to the hospital. That's malingering. My neck, oh, yeah. Okay, so that's malingering. Factitious disorder is falsification of symptoms without a clear gain, right? So in malingering, you've got a clear gain. Either you're getting off work, or you're going to get some money, or something's going to happen, like you're going to get out of jail time. We see people who plead insanity who don't meet the diagnostic criteria for that. So clear gain. Factitious disorder, not a clear gain. We don't really know. Like, we think that there's like a secondary gain of sort of being in the sick patient role. And then there's factitious disorder by proxy, which is faking symptoms in a child, right? So it's a pretty severe pathology of a parent, very, very difficult to identify, very, very difficult to address. Illness anxiety disorder is constantly worrying about what's going on, and not ever being assured, right, that you don't. My grandmother used to have this. She thought she had cancer. She would go to doctor after doctor after doctor. You don't have cancer. You don't have cancer. You don't. But I'm sure I have cancer, right? So that's illness anxiety disorder. Conversion disorder. I said PNES. That's one of the most common types of conversion disorder I see. We also see conversion disorder blindness sometimes, where there is no physiological explanation for the physical symptom. So PNES is psychogenic non-epileptic seizures, right? And so there is not seizure brain activity, but the seizures are present. And they're very debilitating. So this is not faking. This is usually something has happened in somebody's life and it's manifesting in physiological ways. And we're going to see this more and more, I think, as we develop more sophisticated research, because our bodies and our minds, that whole mind-body dichotomy, that separation of mind and body, I think we're going to find more and more that doesn't exist, right? We're already finding that there are as many dopamine receptors in the gut as there are in the brain. So we're finding more and more that our bodies and our brains are connected in ways we never really knew before. So we see conversion disorders happen. Sometimes it's paralysis, sometimes it's blindness, sometimes it's seizures. Yeah.
For the malingering disorder, how do you differentiate that like an actual disorder versus someone that is doing something just to get away with it, just so they don't put extra effort into taking faking an injury on work just so that they don't have to put in the effort for work but still get some income.
That is malingering. So malingering is actually not a disorder. Malingering is just faking.
So it's just put up, okay.
Yeah. So it's classified under somatic disorders, but it's mostly so that you can do a differential diagnosis, right? Because if there is some clear gain, if there is benefit, it can be time benefit, effort benefit, financial benefit, benefit of getting out of punishment, right? All of those things are still malingering, okay? Eating disorders, it's worthy to note that anorexia, not depression, is the most deadly psychological disorder. Anorexia, not depression, right? That is the number one most lethal diagnosis that we have. So anorexia nervosa requires, it requires a low BMI. So this is a ballpark, below 17 BMI. And then there are degrees, right? So there's mild, moderate, and severe, depending on how low the weight has gotten, right? And we see a lot of other symptoms that might be things like amenorrhea, which is a period stopping for a female, or like the downy fur that can grow on the skin when you don't have enough body fat to keep your body warm. So we see some things like that. Note that both anorexia and bulimia have binge and purge subtypes, right? So you can have anorexia and have binging and purging subtype of anorexia. The hallmark is, the reason you have anorexia is your weight has fallen below a reasonable level for body sustenance. Okay? The primary forms of treatment for anorexia, the very first order of treatment is conditioning to get weight back on, right? This usually requires intensive treatment. If it's not inpatient, a lot of times it's very intensive outpatient, so several hours a day, right? We do operant conditioning sometimes, we do behavioralism, and sometimes we do whatever it takes to get food in that body, to get weight back on that body. Yeah.
Okay, so one of my friends that I'm like really close with,
Uh-huh.
she does not eat like at all. Like when she does eat, she'll eat like small things like applesauce. She'll eat like chicken nuggets, but she doesn't eat anything major. It's because she thinks she's fat.
Mhm.
She's not. She runs and stuff. But she doesn't eat at all. She'll go like a whole day. She'll come to practice and like almost pass out because she doesn't. So like we've been trying to like find ways to talk to her about it or like get some help. But she doesn't eat at all. Like it concerns me. So
Yeah.
how would you go about that?
So this is one of the also most difficult disorders to treat. And it's because it's supported by society. It's supported by cognitive distortions. Hold on one second, Nicole. So there are cognitive distortions that get in the way of being able to have accurate perception. There's also what's called body dysmorphic disorder, right? Where I look in the mirror and instead of having an objective picture of who I am, I see something that is dysmorphic, right? I can only see some element of like my hips being too big or my thighs, or like I only see those things. And body dysmorphic disorder results in a lot of times plastic surgery after plastic surgery after plastic surgery, and it's kind of an obsessive compulsive disorder, right? So with that one, you treat it sort of more like you would do OCD, which is exposure and response prevention, but you also have to address those cognitions. It's really complicated, and I would get either a trusted coach or parent or somebody that person cares about and can hear things from involved in having that conversation. It's really, really hard to come up with a specific plan for that. You could actually go and do like a consultation at the counseling center and say, here's the things that I'm worried about. How is the best way to proceed? And you can come up with a specific plan. It would just be a consultation, like it would be a one-time appointment.
Her parents are the ones that tell her she's big.
Yeah. Yep.
I feel like that's where that comes from. She's not.
Yeah. What were you going to say?
When I was in a normal, I was doing things on anorexia. Yes, they're very conscious about their looks, but a lot of what I was seeing had to do with control.
Mm-hmm.
Controlling the female, so I basically control
Mm-hmm.
what goes into the body.
Mm-hmm.
What does this fall into with internal and external locus of control, and is it possible to say they have an external locus of control they're trying to get help from by, this behavior?
Yeah.
Would it be possible to change them to have an internal locus of control, or like would that affect their behavior?
Sometimes it's highly, highly internalized locus of control that's the issue, right? So I am going to control this. I am going to control these different elements. There's a lot of perfectionism that's associated with it, and deconstructing and unpacking all of those cognitive distortions, or there may not even be distortions, like it might just be cognitive habits, is really, really, really a lot of work. And it's not at all uncommon to see high levels of perfectionism and to see high levels of feeling of needing to control. Yeah, that's really, really common. So know that treating these disorders is really difficult. Bulimia is a little bit easier to treat, straight bulimia, because there's not the associated weight loss. Because what happens is, right, if you think about it from a behavioral perspective, then people are really reinforced for extreme weight loss until they get to a certain point, right? And then it starts to freak people out. But up to a certain point, people are like, oh, you've lost some weight, you're looking really good. Oh, and then it's really reinforcing. And so it creates this sort of self-fulfilling prophecy, or like this negative cycle, a downward spiral. Substance use disorders, you can have mild, moderate, or severe, right? And you have to have 2 or more in a 1-year period. The more you have, the more severe the disorder is, right? So if you have tolerance and withdrawal, and you get drunk way more often than you intend to, and you don't go to class, and all you think about is getting drunk the next weekend, right? That's more severe than if you have had a DUI and your boyfriend broke up with you because of your drinking. I mean, not all of those things are severe. Just the more symptoms you have, the more severe typically. Okay? We have paraphilic and sexual disorders. So I am not going to go through what all of these are, but recognize that paraphilic disorders, the object of your sexual desire is something that's not necessarily sex, right? So the object of sexual desire, or what's required in order for you to feel sexual desire, your sexual desire is paired with something else, okay? And then with regard to sexual disorders, they're typically divided out into male and female, and they're usually related to pain or difficulty with arousal, or too early arousal, or too late arousal. So there are different types of treatment for those different types of disorders.
These were made a lot of our developmental questions. Like in our developmental quiz, like it was mostly like sexual disorders and paraphilics.
It was.
Yeah, it was weird.
That is weird.
Like
on Blackboard where it said what chapters it was, one of the chapters was actually like sexual development.
Oh, yeah. So the book really focused on these things in terms of sexual development, more sexual disorders than sexual development.
It asks a lot about like erectile dysfunction disorder and sexual sadism.
Okay. Praise! Okay. Well, I'll note that and I'll make some changes to the quizzes. So thanks for telling me. Okay, neurocognitive disorders. Formerly known as dementia, right? You're hearing a lot of formerly known as things from the DSM-4 to the DSM-5. So neurocognitive disorders were formerly known as dementia. It can be related to a lot of different things. So just recognize that the cognitive dysfunction is usually related to something, right? And if it's related to a substance use, then it's not a neurocognitive disorder. And then personality disorders. So those are enduring problems with forming stably positive identity, structuring close and constructive relationships. There are 3 clusters of personality disorders. You've got the odd eccentric type, you've got the dramatic erratic type, or you've got the anxious and fearful type. So this is the one I was talking about before, OCPD, extreme perfectionism, high levels of anxiety, fear of imperfection, right? Or you have avoidant, I'm not going to do anything because I'm not worthy to do anything. Or you've got dependent, which is I need somebody else to tell me what I can do, what I'm good at, right? Your odd eccentric, so your schizotypal is the one with the magical thinking. The schizoid sometimes gets confused with autism spectrum disorder. Schizoid is not interested in relationships, just not. Don't care, don't want to be around people, don't need them, and they don't. They don't care, they don't want to. And then paranoid is if you have paranoia, and it doesn't necessarily rise to the level of requirement for it to be like psychotic. And then cluster B are the dramatic and erratic types. So this is where you find antisocial, borderline, histrionic, and narcissistic personality disorders. one of the problems with personality disorders, there are a few, right? So one of the problems with personality disorders is they're not as stable and enduring as we used to think. They're not as stable and enduring as we used to think, and also there's a lot of comorbidity, so they're not real clear, distinct constructs. Okay, and then finally, ethical considerations and cultural impact. Know that one of the biggest ethical considerations is removal of freedom. Institutionalization, hospitalizing somebody against their will. When can we do that? When is it not okay? Maybe we can talk more about that after spring break when we get into the more conversations about ethics. And then cultural impact. We have bias and psychometric measure, culture-bound disorders, differential response to treatment, and likelihood to seek treatment. Okay, go! And I'll be here on Thursday, so if you want to come and talk to